Hello again, everybody. So we're going to be going over the endocrine system, and this one can be sort of confusing, just with all the different syndromes and stuff. And so bear with me. Okay, so let's start off with an insulin review. So this is going to be really important for exams, HESI, life, whatever. So just know the process of subcutaneous like administration. So like you don't want to inject too close to the belly button or on top of bruises. And the reason like most injections are given in the abdomen is because it's absorbed the quickest there. Okay. So first off, we have rapid acting insulin. And so has an onset of 15 minutes. So you're going to want to know for every insulin the onset, peak, and duration. Okay, so onset 15 minutes. Because it's so quick, we want to make sure that their food has actually arrived when we're giving them the insulin so that they don't bottom out before they have a chance to eat. The peak is about 1 hour and it lasts about 2 to 4 hours. And we want to make sure that we're educating diabetic patients to time their exercise with their insulin. So, because exercise decreases blood sugars, and if they took their insulin and they plan on exercising an hour after, but that's when the peak of this rapid acting insulin is going to happen, they can experience hypoglycemia. Okay. So this is an acronym. I don't know, I just made it up, but to remember the insulins and their names for rapid acting and its lag. And I always say Hannah because my name Hanna, and it's just HNA. But anyways, you do you. So Lispro, Aspar, and Guilicine. I don't even know how to say that, but that's the lag, and then HNA, those are the names that go with it. So Lispro, Humalog, Aspart, Novolog, Guilicine, oh my gosh, Apidra. Okay, so just remembering that those go together. Okay, because it's really easy to get confused between these names and these names, at least for me. Like Lispro, Lantus, Levemir. Okay, and then short acting, onset 30 minutes, peak 2 to 3 hours, last 3 to 8 hours. And so for me, short acting is just sort of double rapid acting. So instead of onset 15, it's onset 30, peak 1 hour, it's peak 2 to 3 hours. Instead of 2 to 4, it's like 3, 4 to 8. Okay. This is the only insulin that can be given IV. So like the drips would be a regular insulin drip. It's also called Humulin R, Novolin R. So for regular. Okay. And then intermediate acting, it's onset 2 to 4 hours, peak 4 to 12, last 12 to 18 hours. Okay, this is our NPH. NPH is going to appear cloudy, and so if you're drawing up multiple insulins in the same syringe, you're going to draw up the cloudy one last, making sure not to inject any of the other insulin into it. Long acting, 2 to 4 hour onset, it has no peak, and it lasts about 20 to 24 hours. You want to eat snack at night, or instruct them to eat a snack at night to avoid a dip in blood sugar in the night. Okay. Glargine is Lantus, and Detamir is Levemir. At least these ones sort of rhyme. Levemir, Detamir. Okay. This is a really, really, really important picture. You should memorize it, understand it. I'll leave it at that. Okay. Some other medications regarding the endocrine system, we have levothyroxine or Synthroid, a very common one, especially if they've had their thyroid taken out. It's to replace those hormones. Some side effects can be insomnia, so you're taking it and giving it in the morning on an empty stomach can cause hypotension, tachycardia, and anxiousness. Make sure to, this is an important point, to talk to provider before changing the brand due to differences in bioavailability. So different brands have different like pharmacological implications in the body. We just want to make sure we're aware if they want to change brands for like insurance reasons, it's cheaper, la di da. Melatonin, natural sleep aid. We make melatonin in the body, and it can just help people maintain their sleep throughout the night. However, too much melatonin has an opposite effect, so it'll keep you up. Yeah. Metformin, glucophage, pretty important medication, usually is prescribed to type 2 diabetics who do not require insulin but need help regulating their blood sugars. It stops glucose production in the liver. Some side effects could be GI disruption, a metallic taste. Most important part about metformin is it needs to be discontinued at least 2 days, 48 hours before any contrast CT scan. It will just interfere with the contrast throughout the body. Okay, pioglitazone, Actos is another type 2 diabetic drug. It's an anti-diabetic. Side effects can include chronic heart failure, edema, hepatitis. Estrogen or Premarin, this is an estrogen replacement for women. Side effects, it can cause deep vein thrombosis. That's why also with like oral contraceptives, it can cause deep vein thrombosis because of the estrogen contained in it. It can cause stroke from those DVTs, liver problems, increased breast and endometrial cancer risk. Okay. All right, I won't go through all of this, but this is just a good picture reminding you of where all of these hormones originate, and like what organs they have an action on. Okay. This is another good one that shows you like the anterior and posterior pituitary in connection with the hypothalamus because they're like the major hormone producers for the body, and what target organ they affect. Okay. So the anterior pituitary, we have growth hormone. That is a drug. You can see here. Where is it? Right here. So it affects bones, muscles, and organs. So acromegaly is too much growth hormone causing enlargement of hands, feet, face. Can also cause diabetes, heart failure, and hypertension. And this is for adults. And then gigantism is in childhood. So too much growth hormone in childhood. And the whole body grows very large, not just like hands, feet, face. Okay. Hypopituitarianism, most likely caused by an adenoma, so a tumor pushing on the pituitary. It can be selective, so just a couple hormones are too low or not produced. It could be pan-hypopituitarianism, pan meaning everything, so all hormones not produced. And then just as a knowledge point, transsphenoidal hypophysectomy, it's a mouthful. If they had that done, we want them to not vigorously cough, perform the Valsalva, or bearing down. They don't want to lie flat. Brushing teeth is contraindicated for 10 days. They're going to need replacement hormones for life. Okay. All right, so the posterior pituitary, some issues that can happen with that is there is, oh my gosh, words. ADH is produced in the posterior pituitary. So diabetes insipidus is a deficiency in ADH, can cause polydipsia, so increased thirst, polyuria, increased urine, hypotension if they're fluid volume deficit, and dilute urine, so their specific gravity is less than 1.005, as well as electrolyte imbalances because of that wasting. So ADH is responsible for retaining water, salt, and regulating blood pressure. But if you don't have ADH, it's going to be flushing, like your body is just wasting. So super intense thirst, tons of pee, stuff like that. There's 3 types of DI. First, most common is central. It's neurogenic, so it's just caused by the nervous system. Nephrogenic, so kidneys not responding to the ADH, and then primary, high water intake, maybe caused by like a mental disorder, like schizophrenia, bipolar, something like that. They're just drinking a ton of water, and it's causing like this diabetes insipidus. Okay. And then the opposite of diabetes insipidus is SIADH, so syndrome of inappropriate ADH. So it causes fluid retention, dilutional hyponatremia. There's so much water that the sodium balance is low. So we want to put them on seizure precautions and slowly correct the imbalance as to not cause neurological damage. Hypochloremia, sorry. So anytime you have low sodium, you're going to have low chloride. They're just friends, they go together. Okay. And then concentrated urine. And so your specific gravity is going to be over 1.030 now. Vasopressin or ADH receptor agonist, so any medication ending in vaptin, like conivaptin, tolvaptan, they're going to like reduce the effect of ADH in the body, allowing things to go back to normal. Okay, so these are opposite disorders dealing with ADH coming from the posterior pituitary. Okay, thyroid, very, very important. Goiter is a term describing an enlarged thyroid, often caused by an iodine deficiency. That's the most common cause worldwide. Another condition, thyroiditis, itis meaning inflammation, causes fever, tenderness. Because it's so inflamed, it's so close to our airway that we want to monitor the airway and make sure that's not being closed up and that they're not going to need to be intubated. Okay, acute thyroid toxicosis. So this is another fancy term for a thyroid crisis or a thyroid storm. There's all the symptoms of hyperthyroidism, like basically heightened. So they're agitated, they may have delirium, seizures, abdominal pain, diarrhea, vomiting, coma, hyperthermia, severe tachycardia, heart failure, and shock. So everything like hyperthyroid is just like everything's like heightened. Metabolism is kicked in super high gear. So that times like a million for thyroid storm. Okay. Hashimoto's is hypothyroidism. They have a high TSH and a low T3. T3 is the active form, and T form is like the inactive form that acts on like the body. I don't know. And so it's like, yeah, the metabolism is going to be affected with thyroid the most. So everything slows down with hypothyroidism, more depression, periods are slower, they have goiter, myxedema, meaning like they have like mucus-like sacs scattered throughout the body, which can create like, I don't know, joint problems and stuff like that. Myxedema coma. So if like anything causative, like an infection, cold, stress, opioids, or trauma, can cause a myxedema coma, causing tongue edema, fluid electrolyte imbalances, acidosis, hypothermia, hypotension, and possibly cardiac collapse. So, a pretty big deal. The treatment for anything like this, we want them to be warm because everything slows down. They're cold, so keep the room warm. Hydrocortisone is like the gold standard treatment for myxedema coma, Hashimoto's, like flare ups, T4 replacements, and fluids. Okay. Um, yeah, another thing is like we want low calorie, low cholesterol because their metabolism is slower, so they gain weight easier and hold on to weight easier. And also the thyroid replacement medications, so like the levothyroxine or Synthroid. Um, Another like just random fact is amiodarone, which is a heart medication. It's like to calm irritated heart muscle, can cause hypothyroidism. So just keeping aware of that. Then we have the opposite of Hashimoto's, which is Graves' disease. This is hyperthyroidism, which is a low TSH and high T3, T4. So exactly the opposite of Hashimoto's. Hypermetabolism, so everything is running fast except periods. Think like sympathetic nervous system, just like going crazy in the body. They also have exophthalmos, so like the protruding eyes. So treatment would be like a cool room because they're going to be like a little feverish, less blankets, beta blockers to protect the heart, more calories and vitamins because they run through their metabolism is on high drive. They're running through those things really quick. Anti-thyroid medications, eye drops for moisture. You want to protect those eyes that are protruding. Radioactive iodine to try and kill some of like that excess stuff going on in the thyroid, or a subtotal thyroidectomy. So just taking out the thyroid. And remember from our fluid and electrolytes video, if the thyroid is moved, the parathyroid is really close to it and can be damaged with removal. So we're monitoring for hypocalcemia because of its proximity. Okay. Okay. If there is cancer in the thyroid, it's going to be hard, painless nodules on it. A thyroidectomy, one thing to keep in mind, just have a tracheostomy tray at the bedside in case of airway collapse, and you need to bypass that airway collapse by doing a thyroidectomy, or not you, but the doctor and you're assisting with it. Okay. Parathyroid gland. So we just talked about that. That's right behind the thyroid. Hyperparathyroidism is going to cause hypercalcemia, hypophosphatemia. So remember, those are like opposite. When you have hypercalcemia, you have hypophosphatemia. Just remember the signs and symptoms of those we went over in the last video. Treatment would be a parathyroidectomy, so just taking it out. High fluid intake, biphosphonates. Remember not to instruct them not to lay down for 30 minutes and drink lots of water. And this is just the reuptake of calcium into the bones. And then moderate calcium intake. So we don't want to like stop it, but the whole point is we're just trying to get calcium back into the bone and not in the blood, causing all these issues. Hypoparathyroidism causes hypocalcemia. We're watching for tetany, tingles, mostly iatrogenic causes, so accidental damage or removal during thyroidectomy. Iatrogenic is just a medical procedure causing harm to another part of the body. Remember hypocalcemia, we have Chevostek's and Trousseau's, the blood pressure cuff, the hand's going to flick. So, okay. This is the hormone stuff on the kidneys. And so we have the cortex and the medulla. The cortex makes androgens, aldosterone, cortisol. Cortisol is that stress hormone. Aldosterone is the helps monitor blood pressure, fluid, and slow water and sodium retention. Androgens are like sex hormones. And then medulla is epinephrine and norepinephrine, or adrenaline and noradrenaline. Okay. So let's keep going. So the adrenal cortex, going off of that, Cushing's syndrome, high corticosteroids or glucocorticoids. So Cushing's can be caused by exogenous steroids. So they're getting prednisone shots or prednisone PO, or they have an ACTH secreting pituitary tumor. ACTH is the precursor to steroids in the kidneys. Okay. Signs and symptoms would be central obesity, moon face, striae, which is stretch marks, buffalo hump, hirsutism, so excessive hair growth, hyperglycemia, hypertension, hypokalemia, and osteoporosis. Okay. Addison's disease, low glucocorticoids. So these are the opposites again, Cushing's and Addison's. Mineral corticoids and androgens from autoimmune disease. So autoimmune disease causes the low amounts of these corticoids. Okay. Signs and symptoms, they're weak, they lose weight, they have bronze skin. Treatment, this is really important, is hydrocortisone. So it's replacing the corticoids with hydrocortisone because it has a gluco and mineralocorticoid in the medication. If they're like super stressed or ill, they need to receive more of this hydrocortisone to prevent Addisonian crisis. And this crisis, signs and symptoms would be hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia, fever, weakness, confusion. The treatment would be shock management, electrolyte correction, as well as giving hydrocortisone or hydrocortisone. Okay. We also want to teach not to abruptly stop taking the steroid because that can send them into an Addisonian crisis as well. Okay. This is just a good picture to understand the difference between Cushing's and Addison's and the physical manifestations of that. It's good to go over. Okay, so acronyms for Addison's would be steroid. Like I said, we want to teach to up the steroid when stressed. Don't abruptly stop the medication. They need to add salt to their diet and need to wear a medical alert bracelet. Steroid stands for sodium or sugar low and salt craving. T, tired and weak. E, electrolyte imbalance. R, reproductive changes. O for low BP. I, increased pigment, and D, diarrhea, depression. Cushing's, they have a big risk for infection because of the high amounts of steroid in their body. It sort of like blunts the immune response a little bit. So the acronym for this is stressed, skin fragile, truncal obesity, thin extremities, round moon face, ecchymosis or bruising, elevated BP, striae purple, sugar high, excess hair, dorso-cervical fat pad. So right around here, fat pad, and depression. Okay. The adrenal gland, we have hyperaldosteronism. This is often caused by like a small adenoma, so a tumor pushing on the adrenal gland. So just think high aldosterone, we're going to have sodium and water retention, which increases blood pressure and can cause hypokalemic alkalosis. Okay, so lower potassium equals alkalotic states in the body. Because when you retain sodium, potassium's wasted because of the sodium-potassium pump exchange. Okay. Pheochromocytoma is an adrenal medulla tumor that makes excess catecholamine, so epinephrine and norepinephrine. So just think like your sympathetic nervous system like doubled. So severe hypertension, pounding headache, tachycardia, profuse sweating, unexplained abdominal chest pain. Can lead to diabetes, cardiomyopathy, and death if not treated through surgical removal, the pheochromocytoma. Okay. Okay, diabetes, probably the main one that you're going to see pop up. You will see the other ones pop up as well, but this one is most common. Type 1 is usually diagnosed at less than 40 years of age. It's an autoimmune reaction that attacks pancreatic beta cells that produce insulin. Signs and symptoms: polyuria, polydipsia, polyphagia. So you want to eat a lot, drink a lot, and you're peeing a lot. Treatment: they need insulin therapy. You can't treat type 1 diabetes with drugs or anything like that because their body just simply doesn't produce insulin. And so they need it for life. Especially if they're sick or super stressed or something's going on in their life, they're probably going to need more insulin. Yeah. Okay. So hypoglycemia, cold and remember this acronym, like the saying, cold and clammy, give some candy. You're going to follow the rule of 15. So like 15 grams of a carb, like half a cup of fruit juice. Wait 15 minutes, check their blood sugar again. If it's over 70, like you're going to repeat this process until it's over 70, and then give them a good meal with a protein to regulate their blood sugar. If the patient is unconscious, you're obviously not going to try and like give them fruit juice. They can't swallow. So IV glucose, like glucose 50% through their IV is required. Okay. Yeah, so that rule of 15 is only if they're conscious. DKA, diabetic ketoacidosis, is for type 1 diabetics. So hot and dry, sugar high, super like hyperglycemic. They have metabolic acidosis, they're dehydrated, they're presenting with Kussmaul's breathing. It's just fast and deep breathing to try and compensate that respiratory compensation for metabolic acidosis. They're trying to get off that CO2 and create a more alcolytic state in the body. Blood glucose is over 300 for DKA. Okay. Type 2 diabetes is 90% of all cases, usually from obesity or metabolic syndrome or stuff like that. Diagnosis is like a fasting random plasma glucose test, glucose tolerance test, hemoglobin A1C or glycosylated hemoglobin. Normal is less than 5.7%. 5.7 to 6.4 is pre-diabetes, and over 6.5% is diabetics. And remember that less than 7% is good controlled diabetes, over 9% is poorly controlled diabetes. Okay, so the initial treatment for type 2 diabetics is diet, and you want to teach them to be consistent with their meals, eating essentially the same things day in, day out. Exercise at least 1 hour after meal because we don't want to have them go hypoglycemic. So they need to eat something before they exercise. And then if that's not effective or they're non-compliant, they need oral medications. Metformin is the most common. Insulin is the last resort for type 2 diabetics because like we want the body, they're still making insulin, their body cells are just not responding to insulin as well. And so all these other things are to try and help the body become better, like more responsive. But yeah, insulin is the last resort. Okay, so vaccines are super important for diabetic patients because infections are worse for diabetics. And so teach the patients, be on top of the vaccine schedule, just important. Okay. And then the hyperglycemic syndrome that happens with type 2 diabetics is hyperosmolar hyperglycemic syndrome. And their blood sugar is going to be over 600. They're dehydrated. They have osmotic diuresis. And then another thing that can happen is the Somogy effect, dawn phenomenon. So they're going to have like compensatory hyperglycemia in the morning because of hypoglycemia during the night. And so their body's trying to compensate. And so a way to avoid this is eating like a bedtime snack, like a healthy one before they go to sleep. Okay. Hey, chronic complication of diabetes. So macrovascular, affecting the large and medium-sized blood vessels in the heart, periphery, and brain. And then microvascular complications, we have tiny vessels in our eyes, kidneys, and nerves. So retinopathy is what can happen to the eyes, damage to the retina. So make sure that diabetics are scheduled for yearly eye exams. Nephropathy, they need to be screened for albuminuria. Then neuropathy. So sensory can be hands and feet. And then the teaching with diabetics is we never want to soak the feet, no lotion between the toes, look at the feet every day, wear shoes when out of bed, careful when clipping toenails, like clip them straight across, and no heat packs on the feet. Okay. Autonomic neuropathy is including all body systems. So their body becomes unaware if they're hypoglycemic, gastroparesis, so the GI system becomes paralyzed a little bit or weak. constipation, diarrhea, urine retention, which can lead to UTIs, sexual dysfunction. So that's autonomic neuropathy. So lots of chronic complications from uncontrolled diabetes. Okay, so DKA order set. This is a little complicated. This will be one of your final OSCEs, but hopefully this helps you understand it a little more. I don't have access to the actual order sheet, but I just wrote it down in steps. So first step is they're going to need fluid replacement. So the first 2 hours, they're going to get 1 liter per hour. And then the next 2 to 4 hours, they're going to be getting 250 to 500 milliliters every hour. And then 100 to 250 maintenance fluids, milliliters per hour, okay? So we're starting with a ton of fluids for 2 hours, decreasing the next 2 4 hours, and then maintenance fluids for the rest of the time they're in the hospital, okay? So the first fluid you're starting with is normal saline. If there's sodium, so one of the electrolytes you're going to be checking with a DKA order is sodium. And if their sodium is over 150, they're going to be using half NS instead of 0.9% normal saline. Okay, so fluids is the first line of defense for DKA. So these are labs to watch every 4 hours: your sodium, potassium, blood glucose, anion gap, and GFR. So glomerular filtration rate for the kidneys. Okay. So those are the labs you're going to want to get to know how to switch, like how to, what rates to put your fluids and what fluids to hang for your DKA patient. 3 is to prime insulin. To prime it, you're priming it like normal, like squeezing the chamber, priming it through. You clamp it and then wait 5 minutes. And then before you attach it to the patient, you flush 10 milliliters of the line out before connecting the patient. I'm not exactly sure the reasoning behind this. I think it has something to do with like allowing the insulin like not to like hang on to the sides of the tubing. I'm not exactly sure. But that's how you prime insulin through the pump. I mean, just like regularly. And then 4 is only start D5NS or D5 half NS. So this NS or D5 or half NS is determined by if your sodium is over 150 or not. Okay, so you're only starting this dextrose sodium infusion if blood glucose is less than 200. Until then, you're titrating insulin according to blood glucose. Okay, and you don't need to use math. It's just all laid out for you in that table. You just look, what's their blood glucose? What do I rate? Like, what insulin rate is it? Is it 10 like per hour, 20 per hour? And that's just milliliters per hour for your insulin, okay? You're only adding this dextrose solution when their blood glucose is less than 200, and that's to avoid them becoming hypoglycemic from receiving that insulin, okay? 5, they need a potassium drip because insulin pulls potassium into the cells, which means if you're not careful, your DKA patient becomes hypokalemic. So potassium and GFR kidney function determines how much potassium to infuse. Because remember, if your kidneys aren't functioning, you're not producing urine. If you're not, that's like one of the key signs, potassium, like you need to slow down on giving potassium because they're not having urine output. So both of those things determine how much potassium you're giving every hour, okay? So if 30 milliequivalents need to be infused, remember that only 10 milliequivalents can be given per hour. So 30 milliequivalents of potassium will take 3 hours to infuse, okay? So to switch to subcutaneous insulin, this is important. So know these parameters. You must have a blood glucose of less than 200 to 250, HCO3 or bicarb more than 15, pH more than 7.3 in the blood. Anion gap less than 12. Anion gap is just the difference between cations and anions. It tells you if your blood is like too acidic or not acidic enough, basically. So a high anion gap means acidic. So we want to close the gap. We want it to be the cations and anions to be almost balanced. So we don't have a big gap in between them. Okay. So those are the parameters that you need to be able to switch off the insulin pump to subcutaneous insulin. If you have any questions about this, just visit me in the lab. I work, or anyone really in the lab, like a 4th semester, to explain the DKA order set a little bit better. Okay, practice questions. This one was not nearly as long or crazy. Okay, which of the following assessments characterize a thyroid storm? And the answer is B. So remember, thyroid storm, hyperthyroidism, you're going to take your sympathetic nervous system and increase it by like a million. So increased body temp, increased pulse, increased blood pressure. Everything's in overdrive. Okay. Nurses planning care for a patient with hyperthyroidism. Which of the following interventions are appropriate? So hyperthyroidism, remember everything, metabolism overdrive. A, instill isotonic eye drops as necessary. Yes, this helps with exophthalmos, the eyes protruding. Excuse me. B, provide several small, well-balanced meals. Yes, helps provide enough calories. It's always better to give like 6 small meals throughout the day than 3 large meals. C, provide rest periods. Yes, because body's working in overdrive. D, keep environment warm. No, we actually want to keep it cooler because their temp is higher because of high metabolism. E, encourage frequent visitors and conversation. We want rest, not overstimulation. And then F, weigh the client daily. Yes, because high metabolism can cause weight loss. Okay. Okay. Male client with DI, Nurse Juliet expects to administer a vasopressin. So vasopressin is ADH, which with someone with DI, they're like wasting all this fluid and electrolytes because they don't have enough ADH. So ADH will help them retain water instead of wasting it. Furosemide will just flush out more water, make the problem worse, and regular insulin is for diabetes mellitus, not insipidus. Okay. Okay, someone being treated for Cushing syndrome, Nurse Lizette would expect a decline in serum Cushing levels. So because they're being treated for it, someone with Cushing syndrome would normally have hyperglycemia, but they're being treated for it, so they're going to have a decrease in serum glucose. Because it says Cushing's is a glucocorticoid excess, which would increase glucose. Glucose decreasing means treatment is working. Okay. So someone had a subtotal thyroidectomy during evening rounds. Nurse Tina assesses the client who now has nausea, temperature of 105, tachycardia, and extreme restlessness. What is most likely the cause of these signs? And this is B, thyroid crisis. So this usually occurs in the first 12 hours after a thyroidectomy and causes exaggerated signs of hyperthyroidism, high fever, tachycardia, and extreme restlessness. Okay, and that's just like the leftover hormones. Yep. Okay, so I have SIADH, meaning too much ADH. So which intervention is appropriate? C, restricting fluids. They already have too much fluid because ADH causes salt and fluid to be retained. Okay, and then as well as A, B, and D all have to do with increasing fluids. C is the only one that doesn't. So that's how you would differentiate that answer. Okay, so they are in an unresponsive state. They have HHS. Which would the nurse prepare to initiate or from the anticipated orders that the doctor is going to give? And C, intravenous infusion of normal saline. So with DKA and HHS, they're both dehydrated in dehydrated states, and so they're going to need fluids. And so IV infusion of normal saline to correct that dehydration. Okay. Okay, so they're hypoglycemic. What are they going to have? 1, tremors. So also another, so like anorexia, hot, dry, muscle cramps, will have to do with hyperglycemia. And if you're in doubt, like it's always better to treat for hypoglycemia. Like, so that's just sort of the rule of thumb. And that is it. Okay, good luck, you guys.